Dr. Dash, for giving me this opportunity. Well, I will be dealing the differentiating feature, or rather differentiating task from endophthalmitis. A common scenario, or rather what we face in the outdoor, that when a post-operative case comes, the operating surgeon thinks that's a task, and on the counterpart, the retina person suspects as an endophthalmitis. If this common scenario comes, if this clinical scenario comes in the first post-op day, you operated 8 post-op case. In the first post-op day, you see a horrible vision, intense anterior segment reaction, and you have operated 8 cases, out of which almost similar pictures, 8 are very severe. You really wonder if you ever want to practice medicine again. Now, the problem with the TAS and endop is they present exactly the same many a times. It presents with poor vision, hypopyon, fibrin membrane, but the treatment is different for each entity. In fact, TAS improves in time without a special treatment, but diagnosis of endophthalmitis should be made as soon as possible to achieve a good result. Coming to the differentiation points, first, the timing of the disease. The TAS is an unusual inflammation. On the day of the surgery, usually occurs between 12 to 48 hours, following uneventful cataract surgery, mostly cataract surgery I would say. And endophthalmitis generally presents later. So the presentation, the early presentation indicates more in favor of TAS. Coming to the pain, both can cause significant or no pain, but if a patient complains of a deep and intense pain, it is more likely to be an endophthalmitis. Although pain is quite subjective symptom, it is often highly variable, but most of the studies suggest that there is association of pain with endophthalmitis. As one of the studies has been quoted, that 75% of the infectious cases presented with pain. Coming to visual loss, in endophthalmitis, a very common presenting feature is a marked visual loss. It has been shown by the landmark study, that is the EVS study, that 94% of the patient presented with visual loss. And in TAS, the marked blurred vision is not that common as endophthalmitis. Next feature is the conjunctival and the lead reaction. In a TAS, the lead swelling is uncommon, whereas in endophthalmitis, conjunctival hyperemia and the lead edema is quite common. In this picture, we can see the wound infection, wound infiltration too. Then comes the corneal edema. This is a very important differentiating feature. The corneal edema in TAS is limbus to limbus. It is a 360-degree corneal edema, whereas in endophthalmitis, the corneal edema is mostly localized. An important feature which we should look for is the wound. If there is a wound infiltration, then it is unlikely to be TAS, and we should treat in the line of endophthalmitis. Coming to the iris findings, in TAS, there is a fixed dilated pupil, and later on there will be a diffuse iris atrophy, which is an uncommon feature for endophthalmitis. Coming to the intraocular pressure, in TAS there is a profound impact on the trabecular meshwork. Generally there is a high intraocular pressure, whereas in endophthalmitis, the trabecular meshwork is one of the least sensitive structures, and it is not, we don't see a high IOP in endophthalmitis. We might see, but more common with TAS. So extremely high intraocular pressure early in the postoperative period points the diagnosis of TAS. Then comes the therapeutic response. In TAS, the therapeutic response to topical steroid is a definitive test. The steroids can suppress inflammation in endophthalmitis too, but this is for a short time. The patient's condition is worsening despite the steroid treatment, then we should think about the endophthalmitis. In fact, if the vitreous cells appear or increase over time, one must strongly suspect infection, and the vitreous stab and antibiotic injection, intravitreal antibiotic injection should be given. This is an example of how the therapeutic response differentiates a TAS from endophthalmitis. We see the pre-op picture, intense anterior segment inflammation with a fibrin membrane, and after 4 days with the steroid treatment, we can see it has almost cleared. As we were mentioning that the posterior segment involvement, it is much more in endophthalmitis. What we see in ultrasonography is a dense opacities and the membranous debris in endophthalmitis, whereas in TAS there is absence of vitreous opacities. If it is present, it is very mild, and it is said to be that the anterior segment inflammation seeping to the posterior segment. TAS, as Dr. Prashant had mentioned, tends to occur in clusters, and endophthalmitis can occur individually. In fact, endophthalmitis also can present in clusters, but TAS is more commonly presented in clusters, and if a cluster appears and one of them, if it is suspicious to be endop, then it is better to consider all of them with a clinical suspicion of endophthalmitis rather than TAS. And TAS is always culture and gram stain negative, whereas endophthalmitis, the culture might be positive. In few cases, as it might be negative, but mostly it is positive. Now, to sum up the differentiation between the TAS and endop, the onset of symptom is a very important feature. TAS is always very rapid onset, that is 12 to 24 hours or 12 to 48 hours, as most of the literature suggests. But endophthalmitis is generally a bit later. Pain usually severe with endophthalmitis. Lid swelling is more with the endophthalmitis. Corneal edema is typically limbus to limbus in TAS, where it is localized in endophthalmitis. Pupil is unreactive and dilated in TAS. Intraocular pressure is raised in TAS. Vitreous inflammation is more common with endophthalmitis rather than TAS. And response to steroid, I think the most important, the therapeutic response to steroid is dramatic in TAS, where it is equivocal in endophthalmitis. We have seen the theoretical differences and the clinical features, how to differentiate TAS from endophthalmitis. But what is important, a sincere workup is needed. A patient who presented with TAS should be assessed carefully. The vitreous should be examined carefully to rule out vitritis. In fact, if there is a huge corneal edema or an intense anterior segment inflammation, ultrasonography should be performed. But in spite all of this, still there will be cases where exact etiology is unclear. Then, if that scenario comes, it is better to perform the protocol or follow the protocol for the infectious endophthalmitis and treat the case as endophthalmitis by taking vitreous stab or a biopsy and giving intravitreal antibiotics. So to conclude, until a therapeutic response to topical steroid is clearly present for several days or we can say weeks, endophthalmitis should be a consideration. Thank you.